Hello, in this video lecture we are going to talk about advanced life support. Advanced life support or advanced cardiopulmonary resuscitation is one of the basic maneuvers of intensive care. This is a complex of manipulations that we do in case of cardiac arrest. Let me remind you that in case of cardiac arrest we can do basic or advanced life support. Basic life support is a part of a first aid, which is done by just bare hands by any person, and the advanced life support is done by a specially trained team of professionals, which can be ambulance doctors or intensive care doctors, or basically, according to Russian law, any doctor can be a leader of a team for advanced life support. So, just in two words, we have permanent biological death and we have clinical death or cardiac arrest, which is reversible. So the patient suitable for advanced life support doesn't have response, breathing and circulation, three key points, but this condition is kind of new and it's only been for just several seconds, several minutes, so the patient still hasn't have any irreversible changes in the brain mostly, so any irreversible damage. So if we can do everything correct and if the diagnosis allows us, we can revive the patient. The team ideally consists of 5 people. Now we're going to discuss all the manipulations that are just involving the advanced life support, and after that we're going to name all the roles in the team. So first of all, when we detect this condition, we first start the basic CPR. Remind everyone, all your colleagues near you on your workplace, that chest compressions are the most important part of the life support, whether it's basic or advanced. So when you see that patient is down, you see that there is no response, you firstly shout out, you say, "Hey, can you hear me? Do you need help?" You get no response, then you do check the breathing. To do that we have to, in this case, remove the oxygen mask. Accidentally we remove the hair, that's all right. We remove the oxygen mask so we can reach to the airway. We open the airway, we try to feel it, or now we have a post-COVID era, so in post-COVID conditions we only open airway and we just place our hand like this so that we can feel with our fingers if there is an air movement. We see that there's probably nothing happen. We suspect that there may be a respiratory arrest. Then we have to place the patient horizontally. So we remove the pillow. If there is a pillow, we place the bed down so that patient is lying horizontally. So this is the perfect position for the CPR. Then we open the airway again. We try to feel the airway. Try to feel the breathing once more, and we see that patient is not breathing. We do that for 10 seconds. Then for basic life support that would be enough, but now as we're medical professionals we do check their circulation, so we have to place our fingers, 4 or 3 of our fingers on the carotid artery on one point for 5 seconds, then another 5 seconds on another carotid artery, and now we detect that there is no response, no circulation, no breathing, and now the patient is definitely in cardiac arrest, and we have to start the resuscitation. First of all, we have to start chest compressions, so we open the chest. We place our hands like we would do in normal first aid. We start compressions. At the same time, we of course have to call for help, whether it's like an emergency button or maybe a stationary phone, or in our case a cell phone. So we have to call our intensive care unit. We imagine that we're in a hospital, so we call the intensive care and say that person down, room like 123, please come immediately. We shout for help for anyone, please help, there is a man down, cardiac arrest, or code blue in Western countries, and we start to do chest compressions, just like that, without anything, without interruptions, without any maneuvers with the airway. We just do chest compressions, like 1, 2, 3, 4, 5, so on. Then, as our help arrives, we shift from the basic to advanced life support. So you see that we do not drop chest compressions. So the person who is calling for help is still doing the basic life support, doing the chest compressions. Then, as other persons arrive, you report to them that you see that there is a person in cardiac arrest. You're doing this basic CPR for like some seconds, some minutes. They bring in any special help. For now, we have this is our like subtype of crash cart. So we turn on the monitor, we try to evaluate. For example, this patient in our case is monitored. Of course it can be different, so we maybe have to place some additional monitoring on the patient. So we see that there is no ECG reported, for example, just normally how it happens in different hospitals, and so we don't get an ECG, but we do have a team of, for example, 3 people coming for us, and we are now shifting for advanced life support. What do we do? First of all, we have rhythm check and electric shock, so defibrillation. This is the first point. The second point, we can provide airway protection and ventilation, and the third point, we can provide medications, we can provide drug support. For that we have to do the IV or intraosseous access, so we have to assign our teammates to do all these tasks. As I said, the first thing that we do is we do the rhythm check. To do that, we get a defibrillator going. So you know that defibrillator is something that we do to analyze rhythm and deliver electric shock. It has 2 pads. For example, here we have one that has written apex, so it goes to the apex of the heart, which is here. The same area where we have the green sensor here. So the left mid-clavicular line, 5 intercostal space. Here we set the apex part, and another one is a sternum pad. It goes to the second intercostal space on the right mid-clavicular line. So it goes like this. These pads are round, as you see. If they are not round, if they are shaped differently, then you will have the indications on how to place them. They have to be parallel to each other. They have to be parallel to the spine. This one round, you can place them any way you want. It actually makes no difference. Some defibrillators, they do have sticky pads. If they are stickers, also you have a graphic instruction, so a picture is drawn on where to place them, and you just remove the protection cover, then you stick them, and they stay at their places for the whole duration of the CPR. So for example, now we have these pads, we place them on these areas, we check the rhythm, and according to the result of the rhythm check, we have 2 possible algorithms. We have shockable and non-shockable algorithms. So let's review these ACGs that we see on the monitor. We have 2 algorithms and 4 possible ACG options. First of all, we have 2 shockable rhythms, so rhythms which require the electric shock. We have the ventricular fibrillations, or VF, which is something like this. Just let me draw at first, and I'll explain. Then we have the VTAC, or ventricular tachycardia, or the VT, which is something like this. Then we have the asystole, which is probably the most famous ECG. And then we have the pulseless electric activity, which can be like something like this on the ECG. So these are shockable, these are non-shockable. How does it happen? You remember that normally heart must have a normal contraction due to the conductive system and the muscular system. They work together, they do the normal sinus rhythm, so it happens like this normally. Yeah. In case of ventricular fibrillation, all the cardiomuscle cells, cardiomyocytes, they work at their own pace, just how they want, without the indications from the conductive system. That's why we have this ECG line. So some something is working on the ultrasound or with the external view, if there's like an open heart surgery, you will see that the muscle is somehow contracting, but it's not coordinated. That's why it doesn't get any pulse. So this contraction doesn't really move any amount of blood. As for ventricular tachycardia, so we do not see the P part of the ECG. You see that there is only really dilated abnormal QRS complexes. So the ventricles, they do contract, but they do that so fast that the heart really doesn't have any diastolic part of the cycle. In this case, it does contract. It's usually contracted, and it also doesn't get any blood inside the heart, so it cannot release it, it cannot pump it, and that's why we also usually don't have a pulse. Sometimes there is a ventricular tachycardia with a pulse. That's why if we see on the monitor something like this, we have to check the pulse again. Maybe there is a pulse. In this case, the patient is not indicated for CPR, but you have to do some additional treatment. We're not concentrating on that right now. In case of, so this is shockable, yeah, so the heart is working somehow, but not coordinated, and that's why we can reboot it with electric shock, and then we can hope that heart will restore its normal function, probably. These are better than this. So in non-shockable options, the asystole means that there is no electric activity in the heart. The heart is dead. That means that there is a chance of revival of patient, but it's really less than in these cases. In cases of PEA, there is an electric activity, so the conductive system of the heart is trying to do something, but there is a disconnection between electric system and the muscular system. That's why these electric attempts to contract the heart are not leading to muscular contractions. So also you will get no pulse, you will get less let's say the least possible prognosis for the patient. So as I said, these two are worse than these two. So in this case, when the heart is still working somehow, the cardiomyocytes, they do have some supplies of glucose, of oxygen inside them, so they still have some power to contract. In these cases, the heart is usually too tired, the supplies are depleted, and it doesn't have really any amount of glucose and oxygen to make the muscle work. So if this asystole is a primary action, for example, if the patient was frozen to death and he's admitted, like after he was found in a winter river, he may be revived. But if first the patient was presented with like a VFib, for example, then there was a resuscitation attempt, and during the resuscitation patient developed an asystole, so it's secondary, yeah? In this case, the chance of reviving the patient is really low, because the CPR was unsuccessful at the first place, and it led to the depletion of nutrition supplies in the muscular cells of the heart. So anyway, we check the rhythm, and we see one of these four options, and we select one of the two algorithms. First of all, let me say about shockable algorithm. So there is a VFib or ventricular tachycardia or VT, and this is an adult patient. So we select the charge and we do the shock. The first charge in adult is 150 joules. The measurement is in joules. So we select 150. We press charge, it charges for like 5-10 seconds, then we place the pads again, we make sure that nobody is touching the patient, we say everybody clear, and then we check again if everybody is really clear, because you know during the emergency it can get loud in the room, so we make sure that nobody is touching the patient. Then we press, in this case, these two red buttons. Also the interface may be different in different defibrillators, that's okay. So we press the discharge, it shocks the patient, then we move the pads away, and somebody is continuing their chest compressions. Also, while the chest compressions are going, now is a good time to think about other key points of the advanced life support. First of all, we have to establish the IV or IO access. In this case, let's imagine that patient already has the IV catheter inside, so we are making sure that it's working, and we prepare medications for the IV infusion, but that's later on. Also, another person might think about the airway support. First of all, if nothing is available, then we at least have a face mask and the ambu bag, so we can open airway and we can do the ventilation, which is done in rhythm 30 compressions to 2 breaths. So somebody is doing compressions, they're counting out loud, so let's say like 25, 6, 7, 8, 9, 30. Then you remove your hands, so you see that the chest can be moving during the ventilation. Then another person, or it may be yourself, is doing 2 respirations with the face mask. We have a separate lecture on the airway protection, so we're not concentrating now on how to do that. You just know that at least face mask, ideally intubation, so let's do that really quickly. Of course, it's done while somebody is doing compression, so usually it's a team work. Now I'm alone since this is a lecture, so that's why I'm doing that all by myself. So you insert the laryngoscope, you prepare to intubate. Now you say stop compressions so that nothing is moving, and you have 5 to 10 seconds to do the intubation attempt. If you fail, you have to remove everything, continue ventilating, and then try again. Now let's say that I am near the vocal cords, I'm pulling the introducer, I'm pulling the tube further away, then I get a syringe, and I inflate the cuff on the intubation tube. Of course, it will be ideal if I have somebody for my assistance. And then we remove the face mask, attach the ambu bag, and from now on we can do ventilations and the compressions at the same time. So someone is doing continuous compression, the depth and the rhythm is the same, so it's 5-6 centimeters deep and 100-120 per minute, so twice per second, like 1, 2, 3, 4, 5, 6, 7, and so on. And another person is doing the ventilation, so one inspiration is 1 compression of the back. It must be done gently yet strong, so it's not like this, but just a normal movement when you compress all the back. And you do that about once in 5 seconds. So somebody is compressing, somebody is ventilating. Ideally we have the mechanical ventilator machine, so somebody is bringing the ventilator and you can select all the modes, you can attach the patient on the tube to ventilator, and then it will, he will be, or in this case she, will be ventilated automatically. Also, if there is no IV access, then somebody is doing it, but now we have it. And we keep doing the CPR for 2 minutes. 2 minutes or 5 cycles, 30 to 2. So somebody, a team leader, must establish a timing and must maintain a timing. Now let's move back to the whiteboard and see the algorithm itself. So, shockable rhythm. We firstly do the rhythm check. We detect the shockable rhythm. We do 150 joules. Then we have 2 minutes of CPR. Then we check the rhythm again. We stop compression, we press the pads again, we see if there is still VF or VT. Then, if the rhythm is shockable, we do 200 or 250 joules. Again, you say clear, everybody is clear, you shock the patient, you continue CPR, so another 2 minutes of CPR. Then we check again, rhythm is still shockable, we do 300 joules, and then we continue with 2 minutes of CPR, and at this point, at the third discharge, so you see 1, 2, 3, 300 joules, at this point we do the drugs. We have two medications for the CPR. The first one is the amiodarone, which is an antiarrhythmic drug, and another one is epinephrine or adrenaline, which is a hormone, which is also good for vasopressin and the improving heart activity. So the dosage is IV or IO, 300 milligrams of amiodarone and 1 milliliter of 0.1 epinephrine. So at least in like Russian dosages and Russian manufacturers, we have 2 ampoules of amiodarone. The one ampoule is 150 milligrams and 1 ampoule of epinephrine. Then you keep doing these 2 minutes of CPR. Of course, it's done at the same time, so somebody is doing compressions, somebody is doing the medication, somebody is breathing. Then after 2 minutes you do another rhythm check. You raise the charge to 360 joules. 360 is the top. The defibrillator will not let you do more because it will not have any medical action, but it will be damaging the heart muscle, so it's like a electric burn. So 360 is the maximum, and all your charges will be every 2 minutes. You do the recheck, you see if the rhythm is shockable, and you do another 360 shock. We repeat the medications once again. So we did third shock, then we did medications, then 4 shock nothing, then 5th shock we do the medications again. In this case we do 150 or 1 ampoule of amiodarone and also 1 ampoule or 1 milliliter of 0.1 solution of epinephrine. And later on we do only the epinephrine every 4 minutes or every 2 rhythm check. That's actually it. That's the algorithm for shockable rhythm. Usually, if we're not successful, the shockable algorithm will not be shockable for like a long time. After some of our attempts, some of our shocks, the shockable algorithm will eventually switch to non-shockable. So one of these 2 ECGs will develop. Also there's a meaning of a bad prognosis, so if nothing happened after all this effort of this long reanimation and patient is not keeping the shockable rhythms but is developing a non-shockable, probably this is not going to end well. Anyway, for non-shockable algorithm, for non-shockable rhythm, the algorithm is more simple. As soon as we detect, so we are now switching all the way back to the beginning of the CPR. We do the rhythm check. We see one of these 2, this asystole or the PEA, and we do not shock since the heart is not working and there is nothing to like reboot. And we also continue CPR. We maintain the airway protection. We bring the IV. And we do not use amiodarone in here, since it's an antiarrhythmic drug and we don't have like a rhythm disorder, we have an absolute absence of the rhythm. That's why we only do the adrenaline, the epinephrine. So we use it every 4 minutes or every 2 rhythm check. So I detected the systole, I have 1 milliliter of epinephrine ready, I place it IV, then 2 minutes of CPR, ventilation, so on, then we check again, nothing, 2 minutes of CPR again, then we check again for the 3rd time, nothing, then we have another 1 milliliter ready, and so on. So it takes up to 8 ampoules of the epinephrine in case of a systole situation. So we every 2 checks we insert an ampoule and then we continue everything and so on. And that's how it's done. So we have 2 basic algorithms. This is like typical situation of CPR. Now, as I promised at the beginning, we disclose the roles for the advanced life support. So let's draw the most simple accident scene. So this is our patient lying on the floor, and as I said, we have 5 members of the ideal CPR team. So the first responder is sitting near the, or sitting or standing, like if the patient is on the stretcher. The first patient is standing from the side of the head of the patient, and this person is responsible for the airway. So he has like some kind of oxygen support, some kind of airway support. He is doing the intubation, he is doing the ventilation with the mechanical bag, or he is detecting the mechanical ventilation. So the first person is the airway and ventilation person. Then we have the persons number 2 and number 3. They are responsible for chest compressions and responsible for defibrillation. So they do have some defibrillator access, monitor access. They change between each other every 2 minutes, like we have an ideal protocol, because you must remember that after 2 minutes of CPR, patient is considered tired, and that's why you have to change with another person. So they are sitting or standing opposite to each other near the chest level. Then there is a 4th person who is monitoring the IV. So he or she is placed in the IV line in the first place, or the IO line, which is usually placed in the leg of the patient. And number 4 is mixing all the drugs, preparing them for insertion, and maintaining the IV infusion. And there's number 5, which is standing with the distance from the leg part of the patient. He is a team leader, so he is a chief in charge of everything, and his responsibility is to make sure that everything is going according to plan. Of course, all these like 4 persons, they are not waiting for the number 5 to give orders. They are trained themselves. They know their typical responsibilities. They have like their bags, their crash cards, so they all take over their responsibility parts. And the number 5 is usually having like a checklist, and he or she has the responsibility for timing, for calling additional services, and he is just making sure that everything is all right. And if he sees a mistake, then he is like adjusting something. So all the team must be pre-trained, must be trained regularly. They must know their equipment. They must be sure that all the equipment is working, all the defibrillator is charged, all the medications are loaded in the crash card. So when something is striking, they are ready, and they are ready to respond as soon as possible. They're not waiting for their chief to give their commands, but they know what to do. Of course, it's great if the shift is working together, if there is a standalone CPR team, which of course is not just waiting for the CPR to come, but they are like normal professionals with their normal responsibilities. But if there is a code blue, so there is a call for the cardiac arrest, they arrive on the scene, and they just don't like fight each other. They just come to the location and do what's need to be done. So this was the basic scenario. Now we're going to review the reversible causes of cardiac arrest. This is a separate topic, which is usually responsibility of the attending doctor, so somebody who is capable of clinical thinking, who knows the medical history of the patient and can obtain the clinical data fast. So basically a team leader of the team. When everything is established, when you see that the CPR is going fine, you have to imagine what could go wrong with the patient. And for your assistance, there is a special mnemonic rule, which is like 4 H's, 4 T's. Reversible causes of cardiac arrest. Reversible means that during the CPR, during the whole resuscitation process, you can do some special maneuvers that may help you bring patient to life. And on the other hand, if there is one of these 4 H's, 4 T's, and you do not fix it, you probably will not be successful in a CPR attempt, or you will be successful but for the short terms, but then the patient will pass out anyway. So what are they? First of all, the H's. First of all is the hypoxia or hypoxemia. So when patient is not breathing, of course the oxygen is not coming from the outside to the patient's lungs and blood. That's why all the tissues are lacking from hypoxia, so lack of oxygen. To fix that, we use 100% of oxygen for all our patients. So if you are breathing with the bag, it can work on the room air, but ideally you bring in the oxygen. The shortest, the simplest way is that you get it from the old tank that probably the patient was getting an oxygen mask, and you apply the oxygen to the mechanical bag, and now you can do the breathing together with room air and with 100% oxygen, and you have to like open it fully on the console. Or if you are doing the mechanical ventilation, you can of course select the flow of the oxygen. You can select 100%, which is pure oxygen, which is for alive people is dangerous for several reasons. Let's not talk about them right now. But in this case, you like have nothing to lose, and you have to select the 100%. Then we have another, which is Hypovolemia. In some cases, like the anaphylactic shock or severe blood loss, or like the severe burn disease, patient may lose too much liquids or too much blood, and in this case there will be a cardiac arrest of the empty heart, like it's like so called. The empty heart means that there is not enough blood coming to the heart, and heart detects that, and the heart does not feel urge to contract. So there is no heart. There's no blood coming in me, then why should I pump it away? So in this case we have to do the massive infusion. We don't infuse like blood and blood products, we infuse only the normal saline and some other crystalloid solutions. We have to replace the volume. As you see, hypovolemia means that there is a lack of volume of the circulating blood. Then another is we have a hypothermia. So if the patient is frozen to death with the decrease of temperature, all the metabolism processes will decrease also, and at a point about 29 degrees centigrade or something about it, at some point the heart will stop. It will stop in the asystole mode, and you will have to do the chest compressions, and at the same time you have to warm the patient up. You can do it with the external and internal measures, like you can warm patient up with hot blankets in the warm room. If you like put some air heaters under the blankets of the patient, and at the same time you can do the internal warming up. If you warm up the IV solutions that you infuse, if you for example place a nasogastric tube and get some warm water or warm normal saline inside the stomach of the patient. So any measures are okay, and only when the patient is warm enough, so if he's like 35-36 degrees, then you check the rhythm again, and if the patient is still in asystole, only in this case you can claim that he is officially dead, deceased, because if he is frozen, then you cannot be sure. You have to do all this process at the same time. So in this case the CPR will not take normal 30 minutes as it would do in typical situation, but the duration of the CPR may be enlarged. So you will have to do it like for 60 minutes or maybe even more, just depending on how well the warming up is going. And another is hypo or hyperkalemia. Hypo or hyperkalemia, which is the elevated or decreased level of potassium in the patient. Potassium is one of the key ions which is measured normally in the intensive care unit, which is responsible for the conduction between nerves and muscles. And if the potassium level is not normal and not close to normal, in this case the conduction of impulses may be different, and the heart will stop contracting just because of this electromuscular ventricular disorders. So we have to do the tests, usually before the cardiac arrest, of course, and if we see that there is a decreased or increased level of potassium in blood, then we have to do something about it to prevent rhythm disorders. First, the patient will deliver a special arrhythmia, and then this arrhythmia will develop eventually into cardiac arrest. So these are 4 H's. Now the 4 T's. The first one is about tension, pneumothorax. Or usually they don't select tension, but they do select thorax. So just if it helps you to remember, then remember the T's for the thorax. So the pneumothorax is a condition when there is air in the pleural cavities. In some cases it may be stable, in some cases unstable. In some cases it may be a tension pneumothorax. Tension means that the air is coming inside the pleural cavity every time the patient is doing the respiration, and it does not come outside when the patient exhales. So every time, with every breath the patient takes, there is an amount of air forming in the pleural cavities. So the patient is getting worse every time with every breath, and eventually the air gets pressurized in this cavity, and there is so much air that it removes the mediastinum, the mediastinal organs, removes it from the side of for the health side, and this mediastinal organs, not usually, but mostly major vessels and the heart, they do have some sensor parts, and when they're like collapsed with this air, they do not get the reflex to contract like they would do in the hypovolemia case, but the mechanism is different, but the effect is the same. So anyway, once everything is compressed, the heart will stop moving. To fix it, you have to do at the same time CPR, and you have to think about this pneumothorax. So maybe the patient had like chest trauma, or maybe there was a central line insertion which could go wrong. So anyway, you see that one part of the chest is like larger than another, it was not breathing, you suspected the pneumothorax, you see that there was a respiratory failure before the clinical death, before the cardiac arrest. So you have to consider that there is a sign of pneumothorax, and maybe you have to do the needle decompression. And if you do the needle decompression, then everything will get back to normal. Patient will like deflate, and the mediastinum will come back to the middle part of the chest, and after that your CPR will be successful. Without it, 99% you will not be able to revive the patient. Then the next one is for the thrombosis. So clots. This T is separated into 2 parts. First of all, we have thrombosis, which is associated with heart, so it's thrombosis during myocardial infarction, and another kind of thrombosis is associated with lungs, so it's a pulmonary embolism. In both these cases, there will be critical damage to the circulation of the patient. In case of MI, there will be a large portion of the heart muscle which will not work properly. In case of PE, there will be a huge amount of lung tissue which will be excluded from the circulation because of this thrombosis. In this case, we have to consider the thrombolytic therapy, and it is done during the CPR. So patient is delivered to the circulation center, so some kind of high-level cardiovascular medical facility which has ability of doing the transcutaneous intervention, which will remove the clot surgically, or you can insert a thrombolytic drug if you're an ambulance team, or if you are in the intensive care unit, which is responsible for treating the cardiac patient, and they do have like this kits and their drugs for the thrombolytic therapy. You know that thrombolysis is something difficult, something that has many contraindications, and there are many cases when you do not use it. still there is a chance of reviving the patient, and then you deal with complications. Also, the prognosis is not good every time. You still suspect that something may go wrong in just any stage of the process. Anyway, then you have the T, which is associated with toxins, intoxications. This is the T, probably the most difficult to find out. You have to think about medical history, you have to ask patient about his complaints, of course, before this accident. So you have to make sure that there is a chance of intoxication, and the toxicant is something which can affect the heart, like for example the cardiac pills, like maybe the digitalis intoxication, and in this case you may find an antidote and you can infuse it before the cardiac arrest or during the cardiac arrest if you think that there is this is the case. We have a tox screen, we have a biochemical panel, metabolic panel, so you can do all these blood tests, but of course they take some time. You usually do not have this amount of time. So if you see that patient is like going into cardiac arrest, then of course you have to think about it in advance. Every condition is better in prevention than in treatment, of course, as we keep saying here on this channel. Of course, for cardiac arrest there is also a good point. And then there is the fourth T is for the tamponade. Tamponade means the tamponade of the heart. In some cases, usually if we speak in some acute situation, probably we suspect that there is a damage to the heart, the injury to the heart, maybe after like an arrow, a knife, a gunshot, or something that could damage the heart wall and damage the pericardium. Pericardium is a sac surrounding the heart, as you remember, and in case of damage there will be a blood volume forming around the heart, and when there is a small amount then it's not dangerous, but if we speak in acute and there is really a good rate of blood loss and the blood is flowing to the pericardium really fast, at some point this blood will compress the heart. So in the pericardium there will be a high pressure area of the blood surrounding the heart, and the amplitude of compressions will decrease, the voltage on the ECG will decrease. It really happens shortly, and patient may feel okay before just maybe 30 seconds before the cardiac arrest. Then the voltage decreases, the amplitude decreases, patient passes out, and then the heart stops working. So if you see this condition, then you have to of course do the CPR, and at the same time you call for the ultrasound. The ultrasound is doing their part of the fast check when they check the heart through the liver or directly through the chest wall, and they do see that there is a liquid forming around the heart. Usually it will look like this, so the heart is something like this, with different heart chambers, and there is a pericardium, and this will be completely black on the ultrasound. So this will be a sac full of blood compressing the heart, so something like this, but in like black and white scale. And you will have to drain it, so somebody must do the puncture. Usually they do that under the ribs, and then with the really long needle they do remove the blood, and as soon as blood is removed, the pressure is removed, the heart may continue to pump again. Also, not every time, but we hope for the best. So, as I've said before, you first of all set up these basic processes. So now we're like reviewing all the topics. So first of all, you do the chest compressions. They are the most important part of the job. Then you call for help. Then the help arrives. They set up the monitoring. They do the rhythm check, and they select the algorithm for shockable and non-shockable rhythm, and they keep monitoring every 2 minutes. Then somebody is doing the airway protection, airway management, and the oxygen support with ambu-bag or with the mechanical ventilator. Somebody is doing the IV or IO, and then you think about inserting some medications, also according to algorithm. And then when everything is set up, you do the reversible causes of cardiac arrest, which are 4 H's, 4 T's. For the outcomes, patient may be breathing again, or patient may restore circulation but may not restore breathing. In this case, you continue the ventilation, but the circulation will be fine. In some cases, patient will restore everything, but usually it's not how it's done. So the consciousness will not be restored because patient has like a huge collapse in every system, so he was like technically dead for some time. Then you can be doing CPR for 30 minutes and nothing will happen. In this case, you think that the patient is deceased, or if there is this kind of special case, then more than 30 minutes, like we discussed before in the reversible causes. So basically 30 minutes of CPR is enough to see if the patient is alive or not. Or you can be doing the CPR for some time and then you see signs of biological death. These signs are early and late. Late signs, they are not really part of CPR but mostly part of the forensic medicine. As for early signs, you see that the skin color will get like some kind of marbleish, and you see that there is like bruises forming on the lower parts of the patient, lower meaning closer to the ground, so the blood will like flow down with the gravity. Also, you must look at the eyes of the patient. You will see that the pupils are dilated at maximum and they are not reacting to light, and if you compress like this from the part, you see that the shape of the pupil will form from the round to something like this ellipsoid. This is a cat eye symptom, so you know that cats, like, they have eyes like this. In humans, we do not, of course, have this type of eyes, but this symptom is positive if the patient is dead, and as soon as the patient dies, the liquid from the eye starting to dry out, and the pressure in the eyeball is lower than in a live person. That's why if you press the eyeball in a live person, you will see nothing, but if you press the eyeball of a dead person, you will see that the shape of the pupil is deforming, the whole eyeball is like deforming, and that means that your job here is done and there is nothing you can do to revive the patient. Of course, we hope that we don't see it, but anyway, that's sometimes if the patient is really ill, that's how it's done. The prognosis is of course different. There is one rule: if the beginning of cardiac arrest was really acute, like electrocution or myocardial infarction or like severe trauma, then there is a bigger chance of reviving the patient, of course, if the therapy is correct. And if the patient was sick for a long time, for example, he was lying on the bed in ICU, like with some kind of severe like infection or any other disease for like several days, several weeks, and so he was going to death anyway, and finally he's in cardiac arrest. You try to revive him, but probably this will not be successful. So the longer was the way towards the death, the worse is the prognosis. So that's it for this time. I hope that was something useful. We remind you that we have separate lectures on the ABCD exams and on the airway management, and we believe that viewing this lecture together will give you a better example on how it's done. And we hope that all your CPR events will be as successful as they could be. So don't forget to hit the like button, subscribe to our channel, and tell your friends about us, and let's be together. Goodbye. Thank you.